everybody to a follow-up session on pedagogy on marvelous medicine. Today, Dr. Ilango Sethu will be talking about teaching and learning surgery, gaps and bridges. Hope to have Professor Ballal joining us as moderator soon. And once he's there, we will just pause so that we can welcome him. Members of Learning General Surgery don't need an introduction to Dr. Ilango Sethu. Nevertheless, as part of the formalities, he's a consultant transplant surgeon at MIOT Hospitals, Chennai. MBBS from Madurai Medical College, his MS General Surgery from Trivandrum Medical College, and his MCH GI and HPB surgery. His MBBS from Madurai and MCH from Madras Medical College. The ASTS Fellowship in Multi-Organ Transplant at UPMC Pittsburgh. He's involved with several research projects and is passionate about teaching and learning. Just excuse me for a minute. Sir? Yes, sir. Yes, sir. We started, sir. We're just waiting for you. Did you click on the Zoom link, sir? The one I sent you on the mail, sir. Which one? Shall I send it again on the WhatsApp? Shall I send it again because we are all here, on the meeting? Yes. So apparently logged in from 10 minutes to 8.
Yeah, ma'am. Professor Ballal is here.
Welcome, sir. Sorry for the glitch. Welcome, Professor Ballal. Good evening, everybody. This being Teachers' Day week, we are extremely honored to have Professor C.R. Ballal with us, teacher of teachers and doyen in surgery. Sir did his MBBS from KMC Manipal, Mangalore, and was a university topper in all the years. He was the recipient of TMA 5 gold medal and also the best outgoing student. Sir did his general surgery also at KMC, and he was of the first batch of MS general surgery of the state. After having qualified as a surgeon in KMC, he joined the Department of Surgery as faculty and continued there for 33 years as the head of the Department of Surgery. Post-retirement, he was the Professor Emeritus at KS Hegde Medical Academy at Mangalore. Professor Ballal is the past president of Karnataka State Chapter of ASI and was the national level quiz master for 6 years. No surgical CMEs in any of the southern states are complete without him as faculty for the past 30 years. Sir was bestowed with the honorary FRCS Royal College of Physicians and Surgeons, Glasgow. He received the Lifetime Achievement Award by the Association of Surgeons of India. A wing of the Narayana Health Hospital, Bangalore is known as C.R. Ballal Ward. And those of you who want to know him better should read his autobiography, which is called Autobiography of a Surgeon. Welcome, sir, and thank you for joining us for this session on pedagogy in marvelous medicine. Dr. Ilango, over to you.
Thank you, ma'am. Thank you, ma'am. It's a pleasure and a privilege to talk to your talk in the marvelous medicine program. I have chosen something which has been very close to my heart for many years. I consider myself a failed teacher because whatever opportunities that life threw at me for being in the actual teaching world, I actually ran away. But throughout my life, I'm very careful about how I learn new things and have been interested in picking up techniques from different people. And some of them I wanted to share with my younger colleagues, and LGS gave me a platform to teach concepts and encourage people. So what I originally did for myself, I shared, and I recognize that is the simple definition of good teaching. For today, I have chosen to talk about gaps in the teaching and learning of the surgical field, I mean, both general surgery as well as specialties, and some of the bridges that I have used to go over those gaps. I'm very much a part of Team LGS, and I find that a real calling apart from my work in transplant surgery. My beginning point is a quotation by Dean Edsall in his graduation address given to the Harvard Med School in 1918. So this was quoted in the Oxford Textbook of Medicine, the second edition, which came somewhere in 92 or 93. And it goes like this: gentlemen, half of what you have been taught is wrong. The problem is we do not know which half. What he said in 1918 still holds true, because we still believe that half of what we teach medical students and surgeons is wrong, and we also don't know what part of it is wrong. This is a paper from the Journal of the American College of Surgeons in 2012, which talks about the trainees' perspective of a training program, general surgical training program. This is a US-based study, and it talks about a 5-year training program that's mostly from a community hospital. And we know that the common procedures listed: bite local excision, lap appendectomy, diagnostic laparoscopy, and lap cholecystectomy are pretty much the ones that the residents are able to perform independently in more than 90% of the patients. The rest of them simply drops down. For right hemicolectomy laparoscopically, only 26% of them were able to complete the surgery from start to finish.
The slides don't seem to be changing unless you didn't intend to change it.
Oh, okay. Sorry. All right. Okay. Now I think I had paused the share. Is that okay? Just check.
Fine, Ilango.
Is that okay?
Yes.
Yeah, it's fine. Okay. So now, at the end of their 5-year training program, we find that 38% of the residents, it's more than about 1/3, are not confident with their skills with 5 years of training in general surgery. This included 23% of the graduating chief residents, the apple of the eye people in a residency program. And now this reflects the choice of fellowship training because they want to bring up their skills to the level where they can practice independently in the community. Now in India, these things are not going to happen. What happened to me is probably the general trend throughout. I was blessed to have very good teachers and an opportunity to operate and hone my skills, even as a general surgeon. And they gave me enormous confidence at the time of my training. But I don't see that happening to everyone. So the question I have asked is, how do we enhance trainee confidence at the end of a training program? Now, this is the American Surgical Association Blue Ribbon Committee meeting on surgical education given in 2004. Quite big people have written it. The algorithm or just shows how a surgeon goes through a basic surgery core, goes through a specialist as a specialist in general surgery or a specialist in different subspecialty surgeries like cardiothoracic, plastic, vascular, transplant, colorectal and surgical, and some additional fellowship modules. This looks very beautiful on paper. And I wonder, even in the United States, where 38% of the residents are not confident of operating independently, it's still remaining a paper tiger 17 years after it was published. Now today, I have done some reimagining in the way surgical education can be done to enhance trainee confidence. The first question is why you train must dictate how you train. Now, what is the actual goal of a surgical training? An economically vibrant and a growing society needs skilled practitioners to meet the needs and aspirations of the society that leads to a fulfilled life. Now, surgery is just one of those skills. A surgical training program exists and must be capable of creating independent surgeons for solving current problems, evolving problems, and future problems. So that is exactly what every surgical training program should aim at. Now, as an individual, we aim to make a trainee doctor independent so that they can restore and maintain the deranged health status of an individual or a society. Now, this looks like a good expectation, sorry, from the society. Now, this requires independence, interdependence, the capability of improving self-improvement, and to think and innovate. So these 4 parts will help the trainee to mature into a good surgeon and be useful to the society in his lifetime. Now, I see teaching surgery as transfer of skills and ideas to the next generation. Now, before I do this, a lot of times I am a copycat. Whenever I see something good, I just take it over and use it for myself. I've used this for techniques. I've used this for principles. I'm used to hearing stories, but I learned these transfer of skills in a very different manner, which I think I can discuss in a later date. But as a teacher, we have to transfer skills and ideas to the next generation. That's literally handing over the baton. Teaching surgery is about how we make others better in our field. Teaching surgery is about how we reduce the cost and the time to acquire skills. I always feel that the cost that I paid to learn some of the skills was really high, sometimes unaffordable for me at one point of time, and took an enormous time to acquire skills. So I always think about how we can reduce the cost and the time to acquire these difficult skills. Now, the goal of teaching is transfer. It is the ability to extract the essence of a skill or a formula and to apply it in another context to another problem that has no similarity, at least superficially. A teacher has to find a method that transfers it all. If we are able to do that, the students will carry a part of the teacher always in his heart. It's like a small child sitting on the shoulders of another person can see farther, more clearly, and enjoy the horizon. So that is exactly the goal of teaching, which I want to talk about. One of the interesting phenomena phenomenon that happened recently is the Khan Academy. I won't see its reasons there for more than 15 years. There are lots of YouTube videos about Salman Khan and the way he built it up. But now these are two clippings from the website. Now, Salman Khan has made education, in school education, free for all. And the skill development for student mastery is highlighted. They don't aim for an 80% success, 60% success. They aim for 100% success. So the students learn at their own pace, do the tests, enhance their skills, and keep moving at their own pace. This is very, very impressive because all along schools focused on a small group of very good students who got the 100%, and then less focus on people who do not catch up to them. But this is one program where they focused on mastery for everyone. Can we do that in surgery? Is a question I always keep asking. The original American training in surgery was a Halsteadian pyramidal training. It was very good in producing a well-qualified chief resident who was capable of practicing surgery independently. Obviously, the problem was that the pyramidal system let only 1 or 2 people graduate at a time and was very difficult for the rest of the team. In India, where everybody gets in, the number of failures at the end of 3 years is quite low. I always wonder whether we are compromising on quality in order to maintain a quantity. The gap in our knowledge is that we do not know what the required quantity of surgery is. And we also do not have good definitions of quality in surgical training in India. In India, MBBS is an undergrad program, unlike the US, which is where it is a graduate program. Between the undergrad program and your specialty in general surgery, there is a variable gap because of the entrance examination, which sort of is a break. The experience during that break time is completely variable. Some people work as general surgeons, some work in ICUs. Sorry, under general surgeons, some people work in ICUs, some people work as general practitioners. So it's completely variable. And the 3 years of general surgery is followed by another gap, another entrance examination, another hurdle to cross to do 3 years of specialty training. And then sometimes another break followed by a subspecialty fellowship, either abroad or in India. Sometimes it lasts as long as 2 years. In the US, it's a graduate program. The general surgery program is between 5 and 7 years. And pretty much immediately, most of the residents, if they want to go for specialty training or fellowship training, they can go to the appropriate subspecialty fellowship. So the break between the training programs is very, very less in US training programs. Now, we do not have in India, we do not have the advantage of or the luxury of doing it in one go. Now, what does a student have to do to excel as a surgeon? So these are the recipes that I use for learning surgery. The first book is the index from Kirk's Basic Surgical Techniques. A lot of students are not aware of this book, which is a generic book about handling surgery and surgical tissues. And it begins with handling yourself. And it teaches you a lot of things about etiquette and how you have to get the job done in an effective manner. The 2 tables which I've given on the right side are learned from a book called The 4-Hour Chef. Whatever we learn, you have to learn how to deconstruct it, because only if you deconstruct it, you will learn what is the minimal required learning unit for success. You must be able to select the 20% out of the 80-20 rule application in order to do it effectively with the minimal possible application of your rule. Then sequencing, the order in which you have to learn, the order in which you have to apply the learning is also very important. And the last one is stake. Now, it's normally stake is supposed to be, what do I lose if I don't do this? But I always say stake is one place in learning where you have to pitch in the board and say, this is the most important thing of all. If you have to do that one particular, if you have to do only one thing, do that one particular thing alone. So that is the stake. The second is the cafe, which stands for compression. You have to compress your knowledge into a single page. If you're able to do that, you become very effective as a student, as a doctor, and then as a teacher as well. Now, how frequently should you revise? So this is something we are working on a regular basis. What's the minimal effective dose? Like, should you revise it once a week or once a month? And you have to learn how to encode so that you can remember them and keep them in your long-term memory, which is very, very essential for a surgeon. Now, this is how I visualize a surgical teacher. Surgery consists of a lot of problems and solutions to those problems and tools to achieve the solutions. Every teacher must know the problems, the solutions, and not just enough to know the solutions. You must simplify the solutions so that it can be easily followed. You must chunk them, that is, group them together so that the students find it easier to learn. You should have the tools. You must be able to identify the tools. So these three components are sections of mastery for the teacher. Now, a teacher's job is like this. You have to discover, you have to develop, you have to demystify, you have to all the problems, the tools, and the solutions. And you have to delegate those responsibilities to those who are working with you or under you. And a teacher must also destroy old, failed solutions and solved problems and useless tools. That is also a teacher's job. I call it 5Ds, the 5Ds of a teacher's job. Now, to be a good teacher, you have to ask, what are your problems and what are your solutions, and match them. If you do that for the student, they will learn and they will become good teachers in turn. There are three different aspects of learning in surgery. For lack of time, I've taken only the first part. Now, the initial part of your surgical training is teacher-driven learning. That is where you have a guide. Mostly it lasts for 3 years. And sometimes it is interleaved with student-driven learning. You have thirsty students, people who are interested, who learn from each other, who bounce the ball back and forth and learn from each other, which is also a very, very important skill for the student. And lastly, when you go out and you're on your own, you have to keep your self-driven learning. There is no place for a medical Rip Van Winkle. So self-driven learning is something that will go a long way in keeping your skills intact. When we teach, one must remember that the student and the teacher reside at the opposite ends of mastery, of course, in ideal circumstances. One of the recently learned words is the word talmidim. Talmidim is a Hebrew noun which means disciples. Now, a disciple is one who studies not only to learn what their teacher knows, but to become the type of man their teacher is. So that is probably the best definition of a student-teacher relationship. Today, I've just taken these gaps, the gaps in operative training, gaps in outpatient teaching, and gaps in inpatient teaching. But being a specialist surgeon, I could not get much on the outpatient teaching, so I'll focus on the first and the last. Resident teaching for procedural skills is something everyone actually loves to listen to and try to improve. A good teacher will make an independent surgeon at the end of his training program, at least to a great extent. Now, I have broken this resident teaching for procedural skills into 8 different parts. The first part is teaching the planning, teaching the access, teaching the exposure, and then ancillary procedures, completion and closure, and division of structures. Then the fourth one is reconstruction. I've written half and half because you have to demonstrate on one side and get the resident to do the other part. Either it's some kind of anastomosis, um, is the most common type we call as reconstructions. Then the fifth stage is just being available in the room, allowing the resident to operate. The sixth one is white light treatment. It's not being in the room when the resident is operate, but just available outside the room in order to give a desirable difficulty to the resident, so that whatever they have learned from you to do as a skill gets encoded and they're able to face their fears. Step 7 is just giving phone instructions and getting the job done. And 8th is declaration of independence. Now, if you dump all of these things at once on a poor resident, obviously he has the pressure of learning and doing everything at once. And that's a lot of pressure on him. So it's important that we take away the pressure of learning and doing at once, like a good teacher. Now, planning is something I learned very well from Chris Hadfield. He's an astronaut from Canada, one of the top-notch astronauts at the International Space Station. He has a class in Masterclass, which is a video, and you can listen to his description of one-pagers and what it takes to be an astronaut. So I have put it up here because as an astronaut, you may not know everything that every specialist in that field requires you to do, but if you take your notes and make one-pagers out of it, you may be able to execute. So for a student, if you teach them how to do the one-pager, they may be able to learn from a cardiac surgeon, and they may be able to learn from a GI surgeon, a surgical oncologist, and keep their knowledge intact at the same time. So the first part of your procedural training program is planning. Now they should realize that if they fail to plan, it's a planning to fail. And all plans, however beautifully written, fails at the first contact with the enemy, usually our disease. Now what I had this habit of being alone most of the time. Just after I finished my surgical training, I had very good teachers, so I could call them and talk to them and do the next step. But once I was about to step out of the institution, MS General Surgery from Trivandrum, I had to learn to keep notes in a way I can process. That is when I started writing these one-pagers. I'll tell you how I keep them. So my methods are to keep one-pagers, every information just in one page. And I standardize the way to do it. I learned this from Dr. R.A. Shastri. Do all procedures in a simple, straightforward, one method as a standard. So I got that standardized for every surgical procedure, which is very, very important for a teacher to teach. After like 14 years as a surgeon, I went on to train for fellowship. And somebody came there and said, this is how we do the incision. So I said, I've done this first. He said, no, you have not done this with me. So they made me do the same thing over and over again till that became second nature. So that standardization is the most important thing that you can pass on to your resident. Naming is what goes on between the communication between the teacher and the student. If you name the process very well, and the student will exactly pick it up from your words. Now we use words like tie the north side stitch, tie the south side stitch, which is not the nomenclature used in any other program. But we are quite comfortable in our team. Everybody knows what it is and follows the same. So you have to name every bit of your process. Now, why do I teach this planning? Is because, as I will highlight a little later, I find that there are 4 situations in surgery: standard approaches, alternate approaches, critical situation techniques, and absolute no-go situations. So each one of them has to be understood. So you have to standardize and name them so that they can be applied in different scenarios. Now, when you, these are some of my one-pagers, evaluation one-pagers. One-pagers provide fingertip knowledge. So you can just get the information in like a couple of minutes. You can revise any procedure in like 2 or 3 minutes. You can read them out of your smartphone. So I converted most of my notes into electronic format. So it's condensed information. So all what you need comes in a single page. So that you have to teach how, you have to create yourself, and you have to teach your student how to create. Now, these are renal transplant one pages. I've just put a picture of me because I was constantly tired all the time, and I had to do a lot of actual surgical work in the renal transplant unit. So what I have done is I standardized the way I was doing surgery. So even what side to stand, everything was done. So the left side shows how I do the incisions, and the right side shows what I prepare, knowing your book Walters, the lines and tubes. So 3 lines. Now, sometimes before, the pre-operative checklist requires 4. Even that is standardized. I take 1 blood group, these are all printouts, 2 cross matches, 3 NATs, and 4 antibodies. It was very easy for me to transfer this to the next set of fellows. So I was only able to transfer this only 1 set. But if you're a teacher in the program, you will be able to get this to many, many residents and fellows, so that the job can be done more effectively, easily, and without stress. Now, what is required for a teacher in intraoperative teaching? The first rule, which I always ask, have you walked that path? You cannot teach unless you have walked that path. Like a path in the wilderness, everything has its variants, and you must be very, very familiar with the path in which you're going. There are 4 teacher skill sets, which I feel is very, very important. One is comprehension. The teacher must know what's going on in the field as well as the big picture. Competence. Now, competence is error identification and correction. So the student invariably will make a mistake. You have to identify the error and you have to correct the error. So if the teacher is very sharp, the surgery will be very safe for the patient. The capacity, by capacity, I mean the cognitive capacity. The student's brain probably will be firing all 100%. But just like the RAM of a computer, the teacher's cognitive capacity should run like 5%. That gives them relaxation, a stress-free environment, and the ability to control whatever is happening. The last one is courage. Invariably, when you allow another person to operate, even in your presence, you are risking some complication at one time or the other. Unless the teacher has walked that path, has confidence and courage to face the fire, they will not allow the student to operate. So courage is a very, very important teacher skill set for transfer of skills. Now, we cannot dump everything on a student at one go. There are 2 big themes in surgery. One is about volumes. You operate more and more patients, you become very skilled. That's one theme. The other is deliberate practice. Practice repeatedly and then go to the field and you excel. Both of them have proponents and then they are critics. We are not going to dwell in them now, probably a little later. So one must identify the student capacity and the operative training and provide them. Now, to teach a good surgical student, surgery proceeds from the surface to depth. Now, we all know that the first surgeries a student does is lipoma excision, sebaceous cyst excision, inguinal hernias, hydroceles. They're all quite surface surgeries. And as they become fellows, they become transplant surgeons or some other cardiac surgeons, they operate deeper and deeper and they go towards the end of the coelomic cavity. That surface to depth learning is a progress in the surgical skills. Now, hollow tissue to solid tissue is also another transfer that you operate on luminal structures first and then go to solid structures. Now, there is a reason for this. The surface to depth learning, instrument control is very easy when you're on the surface. A mistake in the tool handling, all those things can be learned when a person is operating on the surface. There is a wide field. It's an ease of visualization. The needle can move in any direction and still you will get the best suture placement. The anatomy is quite simple. And whatever disaster happens, it is still manageable by the teacher. Now, to hollow and solid organ tissues, there is minimal consistency variation. There are multiple structures within a solid tissue in association with it, in and around it. So that has to be clearly differentiated. And to learn how to differentiate and get that structures is a learning thing. So solid tissue surgery actually comes a little later. And sorry, I wanted to remove this, the last one, content to contemporary. Sometimes you work on structures like kidney or the liver, and damage of the organ will lead to failure. So that also they have to learn in addition and learn those risk factors. The third component is the vascular component of surgery. To handle blood vessels in association with your visceral surgery, that's a very, very key component in the individual steps of learning. And the last one is access variation. Minimal access became a big change 2 decades ago, and now we have robotics that is coming up. So that may completely change the way we operate. Now, all this comes into a single word that was represented by the Hallstedian technique. It's graded responsibility. So all the more, we are not going to go through the pyramidal system. We have to give graded responsibility and ensure graded responsibility so that they become responsible surgeons. Now, there are some things we don't have in surgical training. That is breakdown of steps. One has to break down the steps of surgery so that the student can get a step-by-step mastery. Now, if you take, I have broken down every surgical procedure. This is a generic breakup. People can disagree with me. There are 7 stages of a surgical procedure learning. The first one is access, exposure of the organ to be resected or repaired, isolation of the organ, division of structures, reconstruction of structures, any ancillary procedures, and completion and closure. So they are the 7 steps of learning. Now, to learn a procedural skill, I used to break them up into 3 parts. I learned the access, exposure, and isolation in the first part. I learned to do the ancillary procedure and the closure as the second. That way I impress every teacher that I have worked with, and I allow them to do the division and reconstruction. So I started doing this as a young surgeon in a general surgical unit. I will open the abdomen, I will expose, I will isolate, I will keep and wait. I will allow them to do the division and reconstruction and do the ancillary procedures and closure myself. So these are good ways, but these are also good ways to teach. From the teacher's point of view, break them down into these 7 parts and teach a procedural skill. Division of structures is very, very important, and probably is something they have to see a demonstration and learn them from you step by step. And reconstruction can be done half and half, and they can pick up these skills from you. But the most important thing is that each one of the steps must be replicable. They must be able to do what you do. So that is the most important thing. Now, surgeons have motor skill acquisition. Obviously, the Fitz-Posner, which is very well known, has 3 stages. Cognition is just understanding what's going on. And integration is understanding and then applying the mechanical solution that is required. And last is, you've learned enough and your skills have become automated. So you perform at speed, efficiency, and precision. For a young student, we never teach them to do surgery. It is surgery for effectiveness, the correct surgery done in the correct manner. Efficiency is getting these things done at the appropriate and right amount of time. This is the bottom segment contains what I always tell younger colleagues. Now, there are surgeries which is planned in your brain. You read about it and you do about it. Those are surgeries which you do very slowly. You have fear in your heart. It's never complete. You need somebody to help you. The second stage is what I call the cortex and the spinal performance. Sorry for the repetition. So what happens is that you know a good amount of knowledge and you have quite a bit of experience as well, so that you're able to do parts of the surgery quite well and parts of the surgery where you have to think and do. And then when a person becomes good at it, thinking is not there. This is the time when you see jokes coming out of surgical operations, a relaxed atmosphere. Learning actually proceeds much more faster. The student is very adaptive to the circumstances. But to become an expert, this level of skill acquisition should be persisted with for an extended experience. So each will gain a small step so that in a given domain, an expert will perform it very, very nicely. You should see some of the most beautiful surgeons. Now, being a transplant surgeon, I don't want anybody to just feel that this is the complicated procedure. I just wanted to know about coaching nomenclature. This is how we teach renal transplant surgery. The perfect incision, exposing required vessels, clampings, the two anastomosis, a reperfusion, the tubular anastomosis, check and closure. The rule for teachers is that never leave the operating room with the fascia open. So that was the UPMC rule, which I still follow. And I know that sometimes with the fascia open, if you leave the theater, there is a problem, then it's usually a big problem. Now, coaching nomenclature, for everything, you have to name the event of how it is done. The instructions that are given by the teacher should be loud and clear. Like for the stitches, we say inside out, short the outside, load the inside. So everybody knows where we are. The feedback must be immediate and the warnings also must be immediate. When you complete a process, you have to allow the trainee to check by himself, and then you also check so that the patient remains safe. For reconstructions, half and half in the initial training phase is very, very good. In most of these procedures, teachers as the first assistant will work effectively in training the best surgeons. MET stands for minimal effective teaching. So throughout the surgery, a teacher need not be talking. You must know exactly where the student makes a mistake, and you can put your tips at the spot so that they learn the best. If you have a good senior surgeon, like a fellowship trainee or a year 5 or a junior colleague, and you ask them, you have the capacity to do the operation, can you improve this? This method works very well. The briefing, intraoperative teaching, debriefing, just like how you do the military situation. The debriefing is probably the most important when they finish the process, that they are allowed to reflect, identify the rules, reinforce the learning, and do the corrective steps. So, you know, a guy who operates well and then you enhance their skill. This is something that never happens in India. So it's just wishful thinking on my side. So, but another concept which I want teachers to learn is that, can you teach across the spectrum? Initially, I had highlighted about standard, alternative methods, critical time methods, and no-go situations. Now, a standard one is a defined disease pattern, a recognized surgical situation, and the surgeon's day is good. So it's a standard one. You have a method for that. A defined disease pattern, there is a special situation at the surgical table, but you still have a good surgeon day. Surgeon is all healthy, doing very well, rested, and ready to go. Now, critical times are those when you have bad disease, you have bad surgical situations, or the surgeon just has a bad day. There are situations and lessons for the students to learn. And there are no-go situations which are impossible to correct, which the student must learn not to go. Okay, so these all looks like that it can happen spontaneously in the hands of an expert. But Napoleon had the right solution for it. If I appear prepared, it's because before undertaking and entering an undertaking, I have meditated long and have foreseen what may occur. It is not genius. So if a teacher spends enough time on these situations, they will get to the problem, the bottom of the problem, become better teachers, and produce better students who go on to do the same thing in the future. One of the key operating techniques that we should learn is to teach in absentia. Now, every student, however technically competent, becomes teacher dependent at one phase. So even a good surgical student needs to have the umbilical cord cut in a very sequential manner. Now, how we do it is variable, but I would suggest stay out of the operating room, but inside the operating theater, or completely outside the operating theater. So competence in a surgical student for independence comes from facing fears. It does not come from theoretical learning. And sometimes the best lessons are learned in absence. I've taken two Psalms from Psalms 23 and 22, adjacent Psalms, but they talk of two different aspects. The Psalm 22 talks about forsaken situation, and the Psalms 23 talks about a comfort situation of being together. So if you leave them alone in the valley of the shadow of death, there are things that they will learn very fast. Vidya ma'am, am I taking more time?
Okay, we started late, so we're fine.
Okay. Now, teaching over the telephone, I've got a few more to go. Teaching over the telephone is probably the last leg. Now, you have a confidence in the technical capability of the trainee. Usually, you may have to give just a one-point tip or a few point suggestions. You must have a clear follow-up algorithm. That means you teach them over the phone, call them up. You should ask for their backup plan and personnel. And it's good to do a post-procedure follow-up call. Now, I learned a couple of things like that. So venous involvement and artery first approach. The first time I did it, I had Dr. H. Ramesh on the phone, and he helped me through the procedure by just giving the right tips. I had the same thing with the graft renal vein hilar injury during a procurement. We discovered the vein was injured quite late. Dr. Humar gave the instruction on the phone. We did it. Patient did well. Both patients did well. And I had the opportunity to help out a young consultant who stayed in rural Bihar with no surgeon nearby. And he had never done a right hemicolectomy, just assisted a few, and I could get him through the phone. So it's possible. Teaching over the telephone is possible. You must have confidence in the technical capability of the training. I think we can skip this. Now, to percolate knowledge, it's not volumes. You need gap times. So when you just keep on operating, the knowledge does not get inside yourself. So you need a time to reflect. So that gap time between surgeries is very, very important. Some of the US programs provide 2 years of research time, and that's a good gap time. And medical programs have a couple of months, fellowships have a couple of months to do research as well. It's important to watch others do the same procedure and other different procedures. So you get a wider experience and you can adopt better techniques from other people. The last one is keep deep reflection and diagramming, like drawing simple line diagrams about what you're going to do and how you're going to do, gets you to percolate what you have, the percolation to happen, so that knowledge becomes much more easier in the long term. Now, deliberate practice in surgery is another key aspect of good learning and good teaching method. So as a teacher, you have to define a particular task. Your knot is not good. You're breaking your thread, or your bite is not good, or you have to learn a different technique. So you have to define the task, and you have to define the improvement goal. You have to provide them with a place for repeated practice. And if you're around, they will get an immediate feedback and an expert. Now, this is an ideal situation. But I used to play the role of a teacher and a student alternatively with myself, and I could learn completely new procedures on my own. So this works. Deliberate practice in controlled environments is a way to learn much more complex work in your chosen field. If you want to scale up teaching, one must realize that it is not an adventure unless something goes wrong. Dr. H. Ramesh taught me something round about the same time. How good are you on your bad day? Every surgeon has great days. Surgery goes very well, no complication, everybody is very happy. But there are times when your clamp slips, you have a disaster, you're sick, and you have to face the problem. How good are you on a bad day decides how good you are as a surgeon, how good you are as a teacher or as a student. Now, to get this, you have to space them out. So one surgeon doing all the things continuously is not going to get better and better. So you have to provide the breaks. that will give them a learning effect to reflect and think. Change the context in which they're applying. If you are allowing them to operate easy cases, they will develop overconfidence and fail at a time when they need it. So change the context. If you see a skill, provide them with more difficult problems or in more difficult situations or in newer units. They are desirable difficulties, which enhances the surgical training. So a teacher has to think about these three things in advanced students. Now, expertise is having knowledge, thinking about it, and creating new solutions for any new problem. And like I said, spacing effects, context changes, desirable difficulties, enforce compression and encoding. If your student has learned all the concepts well and has encoded them for long-term memory, these things will test them. Now, surgical training programs have made this objective. This is the Ottawa surgical competency O-score chart. But I think it's not just good enough to put marks on the proficiency of a surgeon. Now, a proficient surgeon has technical element mastery. They do it easy and efficiently, and there is a situational awareness which can never be assessed, but makes the surgical team grow very well. Okay, let's skip this. Now, there is a point in which an inflection point in an operative training where the confidence of the teacher in the student is at really high. And that is when you feel that your student will go outside and perform very well, as good as you want him to be. Now, two ways I see this is cognitive load handling. A young surgeon in the early phases of his training uses up most of his cognitive load, his RAM, to think about the procedure. So there is an intrinsic load is very high. The processing, the germane load, that's the actual true load, linking new information to the old one, also is quite high. And if you put an extraneous load like a loud music or provide distracting information, then I think they will get overloaded. If the student goes to a point in which the intrinsic load and the germane load are handled easily by the student, any extraneous load and discussions can be handled by them, and it will become an enjoyable relationship. So they must be able to process sensory inputs and continue the process. This cognitive load handling happens in advanced surgical students, and they do really well. Now, the second thing which I look for in a student as a teacher is the ability to correct a complication. Now, every surgery does not go smoothly. So they must be able to recognize the complication, define what is wrong. They must prepare for the correction, execute the correction, and then reassess whether the correction has worked for that particular complication and will keep the patient safe. So those two things are the inflection points. Once a student, a resident, or a fellow is able to do that, they can go in for an independent practice. The last point, a few things which I want to talk about is complication management. Every surgery has its own complications and is considered failure by the student as well as by the teacher. But failure is the greatest teacher. Now, for every surgical trainee, the complication management should be taught as a part of your program. It follows the same sequence of training, but don't do it on a complication that's below the waterline, that's at risk to the patient. And I have also learned watching my own teachers fail. I have watched teachers fail in different circumstances, and watching them fail has given me empathy towards myself and towards the teachers, and I have learned critical skills from them. A few things about tool training. There are lots of tools. A young student should spend a lot of time learning about the tools, but I'm not going into that because of want of time. But one should know that this tool is an extension of your brain and your hands. It serves. We cannot make any of the tools our master. Okay. Now, in a surgical round, what do I always ask? The key things which I want the residents to know is to state the timeline so that they know where the student is at that point in the care of the surgical process. They must be able to summarize and simplify and state what's next. They have to learn how to solve the problem. They have to learn to sweat the small stuff. Obviously, you may have done a big Whipple and they might have done the surgery, but they should also know how to handle the hypokalemia in those patients, how to do the DVT prophylaxis in an appropriate way, feed to get the tube feeding done. And they must know how to close the loop with you at the end of the day so that the patient remains safe. So how I do this is I do it once, then I state what I'm doing, then I supervise how they do it. And the next time I just ask. This provides progress in both the senses about the patient as well as about the student. Now, what I don't teach in a surgical round is just how it is given on the right side panel. It's about a big bull shitting. In my training days, this is what we are supposed to do. Don't show authority. On a surgical round, respect to each other is in a different plane. You have to respect the student because he's behaving like a doctor, caring for a patient in front of the patient. So authority will never work. There are some people who continue to behave like the chief makes all the decisions and the resident just carries it out. But I think that's not the best way to teach in a surgical round. Data hopping is when the resident is talking to you about something, just go on, don't jump from the clinical to the examination or examination to the labs or labs to the images. So data hopping is something they will never, provides a situation in which nobody learns. The other couple of things is insulting and ignore. So I don't have to explain this. The last one is sniping, is intellectual sniping, is when key information is withheld from the presenter and is presented at the time of rounds as though it's a big data. So never encourage intellectual sniping in your unit if you want to promote good learning. Maybe we can talk about this a little later. One thing what I wanted to tell about is it's a lot of trainee burnouts, but if you look at the picture, the one that causes the most burnout is lack of recognition for hard work.
We are running out of time.
All right, okay. I think we can say that. Now, most of what I talk about is a dream. But when I hold newborn babies in my hands, I get the same feeling as what I hold when I hold the hands of my surgical assistants and make them do a surgery. There are techniques which I had learned and I have shared. And now it's open for you to discuss about it and what you feel. And I'll be happy to take questions. Thank you.
Over to you, Professor Balal, and Ilango, you can stop sharing your screen.
Yep, yes, ma'am.
No. I would like to know if the people who are attending this particular lecture, have they got any questions to ask? Dr. Ilango, I'm sure will be happy to answer the questions.
We'd like to hear from you first, Chitsa, your comments and your inputs, and then we'll go on to the audience.
Okay, this has been a masterly presentation. How much of it is applicable in our country is a question that is to be asked. There are two things here. Number one, we have over the country different levels of efficiency. There's some excellent institutions where probably many of the ideas which Dr. Ilango has put forward can be practiced. Unfortunately, there are institutions where most of them cannot be practiced. The blame is both on the teacher and the taught. I'm not siding, because you go through LGS, I'm sure Dr. Patta would agree with me. A lot of sad stories come out from the postgraduates and the trainees saying that this is not being done, that is not being done, etc. To that extent, Dr. Ilango's lecture today is exemplary. I think it's more to the teachers than to the taught. His own entire speech today, I think, should be heard by most as surgical teachers, because it tells exactly how things have to be done with absolute evidence, which is today the order of the day. So it has been a very good presentation, but in practice, how much is being applied, how much is being effectively done? Because one thing is true, you ask most of the postgrads coming out of So most medical colleges, they're not confident enough to operate independently. They join as a senior resident, but unfortunately, what is happening today is MS general surgery almost has become a glorified MBBS. So for reasons which are not very clear to me, vast majority move into super specialty or subspecialty, whatever you call it. So when they're working as senior residents, their focus is on preparing for the next entrance exam. I think these entrance exams are something which have probably come in the way of good training, because the time spent in preparing for the exam is at the cost of the care of the patients. Number two, most of the teaching staff do not keep themselves updated to the extent that I would expect them to do. Once they get a good job, I'm talking of medical college, I'm not going to the corporate sector at all, private sector at all, we're only the medical college sector, they do not keep them updated. And therefore, the quality of teaching definitely will suffer in their hands. As he put it very nicely, my training days is a word that is very often heard. And if I were to say my training words, I have to go back 6 decades ago when the commonest operation for a duodenal was a gastrectomy. And I had a teacher who came from Chennai only, was boasting that he had done 10,000 gastrectomies in his lifetime. How many of them are cancer, stomach, late and curve, I'm not aware of it. Anyhow, it's been a very good presentation, but I would like to hear from the audience, specific any particular problem. Dr. Patta, you got anything to add on?
No, my
Or
Dr. Girija Sharma is there, sir. It is a born pedagogue. I think he should come in before I say anything.
Okay, fine.
So, GDS, sir?
We can hear you.
Yeah. Good evening. I think my feeling on this topic is that a boy who gets through entrance test at national level, and when he joins with high merit and he gets out as a poor technical surgeon, a lot responsibility lies with our generation.
True.
We need to repay like what our teachers looked after us. I was fortunate to work under an American pyramidal system, which was a very tough system. But every time anybody operated in the unit, he was assisted by somebody senior to him. All the surgery in the ward was done by the residents. But all the surgeries were also supervised by somebody senior. Hands-on, I must on record accept that the first radical mastectomy I did, those days it used to be Halstadian technique. Dr. Eggleston stood 4.5 hours with me, holding the retractors and cutting the sutures for me. Having said that, I have tried to practice my bit in my life. I have the same patience to hold retractor for my residents. But what I find, like already discussed, that most boys during their second year are more interested in solving MCQs for their urology than doing the patient care. And that is their need. So in the process, many times they come to the theater absolutely unprepared regarding their patient. They know nothing. The histories are not written. Then any teacher would get upset that if he has to take the history himself, then he will not retract. So we have a increasing gap between teacher and taught because the patient care suffers for the sake of MCQ. And second point I would like to say that enough time should be given on rounds. What is missing is the clinical evaluation of the patient in Indian system. Having worked on both ends of the globe, uh, I still feel that the patient care in American residents, lot of resident responsibilities are done by brilliant nurses or what they call PA, the physician assistants. They pick up a lot of things which the resident don't know. I don't know what Dr. Ilango would say.
Yeah, I
Hello?
think PAs are going to be a part of our hospital system in a short time. There's a lot of difference between a physician assistant and a resident. I think we have to train them to apply principles. Physician assistants just follow small rules. I think they do the job effectively, keep the patient safe, but still to take the baton, it takes a medical resident or a surgical resident to actually do the job. They have to do the job of sir.
No, I agree what I'm trying to say. A lot of patient care abroad is taken by physician assistants.
That's true. That's true.
Here that part gets neglected. Neither the resident does, nor there is a PA. So that upsets the guy who has come prepared to assist the resident. When he finds nobody knows history on the floor, obviously, at least
upsetting.
I get upset when I do so much and I find I am the guy to take even the sample history, then it pinches.
So I'll ask Dr. Amit Ghosh to come in. He's another born educator, although a physician. Amit.
No, thank you to Dr. Ilango for a very brilliant presentation, and Dr. Balal for a very actually high-level thought process. I think setting the culture for education is very important. And I take the example of our movie star, Guru Dutt, who had a fabulous career, but he died at age 40 because he'd achieved so much, he didn't know what to do after that and went downhill. And his assistants, who actually was the father of one of my colleagues here, happened to say, he was Kohli, I think he was another famous director himself, that people have achieved so much so fast, so soon, that they have nothing to do. So whenever I see a resident who is more interested in MCQ, they're not enjoying the present day. They are more worried about tomorrow and the glorified MCH and whatever degrees they get. I find them all burnt out at the age of 40, not achieving much, and shrouded with mediocrity. At the Mayo Clinic, when I have to select a surgeon, I do select all the different qualities without knowing exactly the details, which I learned today from Dr. Ilango. But more important is, is the surgeon trustworthy? Can the surgeon give time? Do they have that level of empathy? And this is very important to me when I select a surgeon for my patients. And I get patients from all over the world, and I have to select a surgeon. And those are the characteristics which come, not the technical details. In the past, it used to be technical details. Fortunately, I work in an institution where I have the luxury of having surgeons who are rich in both. They have technical details and the other ability, and I do prefer ones who have both the abilities. In many hospitals, the way it is being dealt with, that you have a degree, and that's what is more, you bring revenue to the hospital, and regardless of your behavior to the patient, your colleagues, or just assessment of how many gold medals you've got, people are advanced in their career, and that's a very wrong method. The instruction which a true teacher gives to a student is what Dr. Sethu Raman, one of our mentors from JIPMER, mentioned. It was written in our book, Samson Wright. It says that the relation between a teacher and a student is that of a cow and a calf. As much as the calf enjoys in suckling milk, the cow has in allowing the calf to suckle the milk. So I would stop the surgery. I would stop the process if I see this attitude in a resident who is more interested, his mind is somewhere else, or I'll have a pre-briefing before. It's my responsibility as a teacher to kind of set those culture part of it so well. What Dr. Ilango really specified is the technical details and the cognitive abilities so important. And a lot of surgeons would not go beyond the cortical, as you said, cognitive and spinal cognitive and others. They will fall somewhere in between and they'll be stopped here if they don't proceed accordingly. So culture in the institution, I'm sure Dr. Ilango's hospital, you know the science, you have set a fabulous institution. I am sure if I were to be a student of Dr. Balal, I wouldn't be escaping at that time. But standing up and saying the right thing, correcting an inefficiency, not being worried about the bureaucracy is a work of every senior consultant, because otherwise it's a very slippery slope of decline and very mediocrity. And I do not understand why our surgical students, residents, and doctors think that medicine has to be all learned within age 30, 35, 40. It's a lifelong process. You can't master it. So you keep learning and learning and learning. And the theoretical aspects and the philosophical aspects only come at the end of your career. You realize what should I have done, what should I have done better, which Dr. Ilango has mentioned. On a other note, when you have surgeons who teach residents, they should go through the curriculum which Dr. Ilango is mentioning here, compulsorily. You should not be allowed to teach a resident or a fellow before you have these attributes yourself, so that you can always bring this up. It should be inside you, imbibed into you, and so you can impart this. In Mayo Clinic, we have this institution which I mentioned about, where we teach our staff before they become educators to learn some of these aspects of higher education, understanding feedback, which we never got ourselves. Our teacher didn't have, but they were intuitively, they did somehow the right thing. But I am understanding, I'm not living in a dream world. All these efficiencies and inefficiencies happening every day, including in Mayo Clinic. All we have to do is that we don't repeat the same mistakes as we see others are making. And that's our responsibility, and that's the only thing we can control. Thank you for the time. And again, it's a fabulous, thank you to Marvelous Medicine. I do not know where you keep getting these fabulous speakers from all over the country and overseas, day in, day out, and Vidya and Patta. Thank you for doing a phenomenal job. I just finished a meeting and I had to be at the tail end. I had to listen to your talk because I saw Dr. Ilango's name. I said, I got to listen to it. Thank you.
Thanks, Amit. I'll ask Bhaskaran for his comments. Bhaskaran, if you can unmute.
Yeah, hi, Radha.
Yeah.
It's a brilliant talk by Ilango, as usual. It's an ideal situation. Unfortunately, we don't live in an ideal world. Teaching, as everybody knows, it's like clapping. You need two hands. Each hand will have to come together. Then only you can clap. And as everybody knows, we fall back in lots of things in our country. But nevertheless, if somebody wants to be a good teacher, there is always an excellent opportunity to be a good teacher. And the pride of being a good teacher, of course, is unique. That outweighs a whole lot of other things. A recent definition of a good teacher I came across is what is available on Google Map. You make an error, it doesn't shout at you. It doesn't tell you, you idiot, you're taking a wrong turn. No, it just thinks, pauses for 2 seconds, and then say, okay, now we reroute you. It tells you and takes you again step by step to where you want to go. So that is what a good teacher should be. I think many of us can try to be like that. Thank you.
Vidya, you got any comments to make?
Can I add on
Yes.
few more things at the end of the show? Because present day, to my own experience, is that the passion for teaching has become considered less as far as the teachers are concerned. We were lucky to have excellent teachers, but today, since I attended so many CMEs, my experience is that the passion to teach, the passion to transfer knowledge has become much less. Of course, as Professor Ghosh is saying, even as an HOD, I used to go and assist the intern for a hydrocele, the PG for a hernia, and my associates, whatever new operation they are doing, I would assist them first, then only allow them. So whether it's being done today, I got my own doubts. Unless you have passion for teaching, your students are bound to suffer. And how to infuse that passion is something which is extremely difficult. The one other thing I should mention here, an unfortunate fact, many of these boys come having paid 1 crore, 2 crores, etc. in some private medical colleges. When they get out, they are least bothered. They demand to be passed because having paid the money, they think it is a justification for getting through the examination. That is happening left and right, which is most unfortunate. And such people remain mediocre. Then with the help of extra finances, they get into super specialties. Ultimately end up being very mediocre people, but making money by very unfair means. I'm sorry to say this, the word cut practice has not been mentioned so far, so I should mention that because all are here, people are knowledgeable people. So this cut practice has ruined the morality of the entire profession, has brought such a bad name. There are things which are to be corrected. How long it will take, I got my own doubts. Thank you, madam. Please conclude this session.
Pradhaban is the head surgical gastroenterology Calicut Medical College for his comments.
Good evening, sir. I was witnessing an excellent lecture by Ilango. I became a good fan of Dr. Ilango. But I worked and I completed my entire training in a government institution. I think it's very difficult for the trade teachers in government institute to have students, every student helped by hand in hand as done by the most of the Western centers. But there are quite difference in the attitude among PGs. Some PGs are excellent, some are very poor in their attitude. I think those with good attitudes get more chances and they will become excellent surgeons by our system. There is, I don't think anything wrong in that, but I think we have to have a very standardized teaching method in India. I think it's lacking in most of the centers. I think Ilango has worked in Western centers and he has worked in Indian centers also. I think he is a person to compare both the systems. Excellent lecture. I witnessed it. Thank you.
Thanks, Pradhaban. Ravi Shankar. Ravi Shankar is a physician and I want to hear from him as to what he got out of this lecture.
So what I got out of this lecture is it was fabulous. I was spellbound. And two, Ilango has, his handwriting is beautiful. And those notes were excellent. Those notes were excellent. And actually I took some of the, screenshots of some of your slides because they make perfect sense, not just for surgeons, but for anybody to learn. So it's just absolutely fantastic. So what RK didn't tell you is that as a physician, I was in an academic center here in the United States for many years before transitioning to clinical research in a pharmaceutical company. And the only thing I miss is teaching medical students, teaching residents, and above all, teaching fellows. I absolutely love teaching pediatric endocrinology fellows because they had made the choice to become a pediatric endocrinologist, which in this country is not a very high paying job. So somebody who chooses that is highly motivated and very interested. So these sort of people made fabulous students. And, it was just giving them any sort of information was like striking a match next to a bale of cotton. It was just so fantastic to see them, grab it on and work on it. And sometimes they would come back and teach me more things with that. So that's the part that I miss so much. And I think Dr. Bilal made that point very clear that there has to be a passion for teaching. And if that passion isn't there, you're not going to ignite it by whatever means. But I also would like to say that this lack of standardization in how people are taught is not just unique to India or to surgery, it's across the board. And I keep thinking that if something as nebulous as an art form can end up with a standardized teaching like in Kalakshetra, why can't we with a science do this? So I think it's a lot of times it's because of this thing of art and science of medicine, and that art, a part of that science is guarded so I mean craftily, if you will, by everybody that they don't want to share it. And that's the part that becomes very difficult, because they feel like if I share it to somebody, if I share it to you as a student, you're going to become better than me, or there's a possibility that will happen. And so there's that selfish fear there that I think inhibits a lot of people from really taking to this with passion, that is teaching other people. But I think that that's a very, very important thing. I think Dr. Sharma said it very clearly that you know, it's time to give back, and that's something that's very important.
Anjali, would you like to say something? Anjali Davle?
Yes, madam. Actually, unfortunately, I have joined late, but whatever I could recollect, madam, it was an excellent talk. And teaching, as the Teachers' Day is coming very soon on the 5th of September. So we at our center have also planned to give something by doing endoscopy training on simulators and on patients. We have arranged a workshop as a tribute to our teacher. The knowledge should be shared. That is one thing. Whatever Balal said and Ghosh sir has said, that it should be a two-way process. And really, madam, I can say the passion of teaching, whichever you, Dr. Patta, have are very lucky to get such teachers. But what I can realize that the quality of teachers over the period of time has reduced. Maybe the technology is made the person to person contact has reduced, and we are mimocrackers, like we can learn from YouTube videos, but we cannot get the sympathy and empathy what a touch and reflection and face expression of a teacher can express. That I can say. An excellent tribute to all the teachers by means of Teachers' Day. Thank you, Dr. Patta.
Thank you, Ilango, for that wonderful talk. And like Ravi said, it's not only related to surgery, it's related, it can be put to use in all forms of teaching, probably outside of medicine as well. And it can be, like you said, many of us are not in the formal teaching arena, or we're not in medical colleges. So it becomes all the more important for us to have these nuances, so that people who work with us, even though they may not be our students, we are able to pass on the baton as it were. Thank you very much, Professor Balal, for sparing your time and for sharing your insights. Thanks to everyone else who joined and with their feedback. Nobody has any other questions. We'll wind up now, and we'll meet again next week with another episode of Marvelous Medicine. Thank you, everyone.
Thank you, ma'am. Thank you.
Thanks.
Thank you very much, Dr. Ilango. Wonderful.
Thank you, sir.
Really
Thank you, sir.
Very nice. Well explained. I don't know how much of hard work has gone into prepare this lecture. I wish you keep on giving the lectures in several other conferences, etc. It's so beautifully prepared. As I said earlier, teachers are going to benefit more than the students. It's the teachers who need your kind of advice. Thank you very much, Dr. Patta and Dr. Vidya. Thank you very much for giving me.
Sir. And again, I've gone through your book. It's a wonderful book, and I'm sure everybody should read it to see your progress in surgery as a student and teacher and professor and teacher of teachers. Nice seeing you, sir, once again. Thanks for joining us today.
Good night. Good night. Good night.
Thanks, Ilango.
Advanced Day, Teachers' Day greetings, sir.
Thank you. Thank you very much. Thank you.